First, I want to thank everyone for joining us here today. We had several hundred registrants for this webinar, which really tells me that both the topic is timely and our guests here today are in high demand. And I am honored to be moderating this wonderful panel of people who have dedicated so much of their lives and careers to helping people who struggle with diabetes. Today's topic is COVID-19 and diabetes, special considerations for reopening America. So really, this is tailored for many different people in this audience, patients, payers, providers, all alike. What is the latest scientific research on COVID-19 and diabetes? I think that's something that everyone is interested in. Another question that is really pertinent in my life and so many parents right now is, how do families cope as children go back to school? And how will patients navigate the uncertainty that has been with us for so long, but continues on in the future as well? And for the providers among us, is virtual care here to stay? And what laws have changed? How can we support and engage populations that are most at risk? We are extremely grateful once again to have a handful of luminaries in the diabetes space join us today and to help shine light on some of these questions. Today joining us is Dr. Francine Kaufman, Dr. Bob Ratner, Kelly Close, and Dr. David Harrison. And let's kick this off today with our very first panelist, Dr. Bob Ratner, who is the Chief Medical Officer of VRTA. Prior to VRTA, Dr. Ratner was the Chief Scientific and Medical Officer for the American Diabetes Association. Dr. Ratner is a professor of medicine at Georgetown University Medical School in Washington, D.C. After 35 years of active patient care and clinical research in diabetes, he served for 5 years at the American Diabetes Association. So we're going to let him kick it off with some of his experiences and interpretation of the literature that is currently available for COVID-19 and diabetes. Thank you so much, Dr. Ratner. Over to you.
Thank you so much, Sarah. It's a pleasure to be here with you and with this illustrious panel to share with you. COVID has clearly been on everybody's mind recently, but as you can see, only 70% of the general public are concerned. I'm guessing that the other 30% are college students. But people with diabetes are particularly concerned about this. Why? Because the impact of COVID on someone with diabetes is significantly enhanced. So when you begin to think about this, you can see why people with diabetes should be concerned. If you simply look at survival from COVID-19, it's about a 95% survival if you don't have diabetes. It's about a 70% survival if you do have diabetes. So the mere fact of diabetes is a significant comorbid condition when one has COVID-19. You begin to look at the literature, and what you see is that the severity of diabetes, the severity of COVID is determined by the presence of diabetes. So in fact, the non-severe cases of COVID are relatively rare among the diabetes population, essentially going from about 5 to 10% of all non-severe cases. But when you look at severe cases of COVID, suddenly diabetes accounts for 15 to 30% of all of the severe cases. In addition to that, if I can go to the next slide, there we go. There's a significant difference in terms of mortality as well. Diabetes constitutes only about 10 to 15% of those survivors of COVID. but 20 to 30% of those who succumb. So clearly there is a disadvantage to anyone with diabetes who suffers from COVID-19. What we've begun to understand is that glucose control plays a critical role in this. Now, that's actually good news because glucose is a modifiable risk factor within diabetes. Here you see some early data from China that simply looked at the relationship between glucose on admission to the hospital and outcomes within a short 4-week period of time. Those individuals who came into the hospital with glucose levels in excess of 180 milligrams per deciliter had an 11% 4-week mortality. On the other hand, those individuals with diabetes who were admitted to the hospital with glucose levels less than 180 had a 4-week mortality of only 1%. So that means there's something we can and should be doing in order to improve outcomes in people with diabetes. Now, one of the interesting aspects here is that it's not simply those with a history of diabetes. It's anyone who's hyperglycemic that is at risk. This is a very large study done across the US by Bruce Bode, looking at individuals according to their glucose on admission. And what you can see is that they have a group that were diabetic by history, who also had hyperglycemia at the time of admission, with an average glucose level of 178 milligrams per deciliter. The control group were those who had no history of diabetes and actually came into the hospital with a relatively normal glucose at 116 milligrams per deciliter. The important point here is that sometimes people become hyperglycemic with acute illness, and there's increasing evidence that COVID may actually increase the incidence of diabetes as well. But in particular, what you see here is that regardless of the history of diabetes, if you had hyperglycemia on admission, your mortality rate was over 4 times that of the control group with no history of diabetes and with normal glucose on admission. And what's perhaps a little bit surprising is that those individuals with no history of diabetes who present with hyperglycemia are at even higher risk than those with known diabetes. Here you can see it's a 3-fold increase mortality rate with no history of diabetes, but uncontrolled glucose. What that means is that we simply need to be aggressive in identifying individuals at risk for diabetes. We need to be aggressive in treating hyperglycemia in all individuals with diabetes because of the ultimate impact that it will have on COVID-19 outcomes. Recently, a group of international experts from the UK, the European Union, and the US came together to develop a consensus approach to dealing with diabetes in the setting of COVID. On an outpatient basis, clearly what you want to do is you want to optimize current therapy. You want to prevent any infections if you can. But I think one of the important considerations here is the last bullet out of outpatient care: to utilize telemedicine and connected health models to maintain maximal self-containment and to maximize glycemic control. Once an individual with diabetes requires hospitalization, then monitoring is critically important, both looking for new onset diabetes as well as aggressive therapy of those with known diabetes. And at the bottom, you can see what the therapeutic goals really are. We're talking about keeping glucose levels, ideally in the 70 to 180 milligram per deciliter range. having hemoglobin A1Cs less than 7%, and monitoring these individuals very, very carefully. Because what we now know from the latest research on diabetes and COVID, people with diabetes are no more prone to getting the infection, but when they are infected, they disproportionately require hospitalization and ICU admission. They also have a mortality rate approaching 20%. Elevated admission glucose is a poor prognostic indicator, and unrecognized diabetes and stress hyperglycemia are even worse prognostic indicators than established diabetes. But ultimately, glucose control during COVID-19 matters. This is what we can do to minimize morbidity and mortality. And with that, I'll turn it back to Dr. Hallberg.
Thank you so much, Dr. Ratner. Next, let me introduce Dr. Francine Kaufman, who will speak more about the intersection of three timely topics: COVID-19, diabetes, and back to school. Dr. Kaufman is the Chief Medical Officer of Sensonomics Incorporated and a distinguished professor emeritus of pediatrics and communications at the University of Southern California. Previously, she was the Chief Medical Officer and Vice President of Global Regulatory, Clinical, and Medical Affairs at Medtronic Diabetes. She is an attending physician at Children's Hospital Los Angeles and previously served as the head of the Center for Endocrinology, Diabetes, and Metabolism. Dr. Kaufman was president of the American Diabetes Association and elected to the National Association of Medicine. She has been the medical director of diabetes camps in Southern California, Ecuador, and Haiti for over 30 years. Thank you so much for joining us, Dr. Kaufman. Over to you.
Thank you so much. I guess I'm not projecting. I'm actually doing this from my phone since my computer just crashed, and I'm still intact as a human being. So I'm a little proud of myself for not getting hysterical over my lost computer at this point. But I'm really honored to be here and talk about some of the real significant issues around school in the midst of the COVID pandemic. So if I could have the next slide. I really want to kind of go through the whys and whats of getting our children back to school. It's obviously imperative that they do go to school, and, you know, really kind of understanding the impact of the COVID-19 infection on children themselves so we can get to understand their risk. What are the requirements of all the stakeholders, and, you know, from the parents, the students themselves, and of course the teachers and administration. And then what about children with special needs, such as diabetes, whether it's type 1 or type 2 diabetes? And then what really should be our national effort? So next slide. It's really a balancing act. I think the one thing we've learned about the COVID pandemic is all of it is a balancing act. And we know the profound harms of having schools closed on children, their academic progress, their social and emotional development, their mental health, their food security. I mean, school offers so much more than just on-site learning. And on the other hand is versus the risk of somebody contracting COVID-19, not just the students themselves, and I'll show you they are at risk, but at markedly reduced risk. But what about the educators, of whom, you know, there are 4 million teachers in our elementary schools, and about 8 to 15%, depending on what survey, are over the age of 60. So for the educators themselves, their family members, and then of course the families of our students, the next door neighbors, multi-generational, in the setting of such uncertainty. So next slide. So when we look at what happened, and I think these statistics are just profound, by April 2020, 192 countries had closed their schools. So effectively, greater than 90% of the world's students, 1.6 billion children, were not allowed to go to school in a physical environment any longer. Over a 10-day period in March, 50 states closed kindergarten through 12, childcare centers, and nearly all colleges and universities. So what are the kind of numbers we're talking about? 21 million in childcare, 57 million children between kindergarten and grade 12, and 20 million college and university students were locked out from their physical environment of learning and of support. Next slide. So, but there were some real positives. I mean, there have been now some projections as to what was saved as a result of closing school. So this shows, and this was reported to, really be some of the most significant data around school closure. So a relative change in COVID incidence per week with a drop of 62%. So a reduction by over 400 cases per 100,000 of contracting COVID-19. A 58% relative reduction in mortality per week, so an estimated 12 deaths per 100,000. So if you extrapolate that for the spring of 2020, we're talking about reducing the number of infected individuals by over 1 million and by the mortality rate of around 40,000. But at great cost. We'll get into all the learning, the emotional, all the other issues, but at cost perhaps to the future of the children who've been affected, and the potential that they have an annual income loss of 2 to 3% over their lifetimes, and that this price tag is in the multiple trillions as far as lost future earnings for these students. Next slide. But of course, what's really important, and I'm a member of the American Academy of Pediatrics as a pediatrician, and certainly look to them for guidance. And after very, very deep consideration from a number of committees of the AAP, it has been stated unequivocally that they are strong advocates that all policy considerations for the coming school year should start with the goal of having students physically present in school. And of course, now we're watching some schools have reopened. I'm in the state of California. The schools are not open here. They're talking about a waiver program to get some of them open. But the goal is to get students back into the physical environment of school. Obviously, it's about academic instruction. It's about social and emotional support and skill building. It's about safety. There's been now a question of how many cases of missed child abuse are we looking at, and how are we going to look at the higher risk of morbidity and mortality from physical and sexual abuse as children are locked into their homes with their potential abusers. As well, substance abuse of the children themselves, particularly obviously the high school and older children, anxiety, depression, suicidal ideation. Schools are an important place where many, many children get nutritional supplement, physical activity. Obviously, a lot of health care is also done in the school itself, and of course, mental health therapy in addition. Next slide. So this is what our children are potentially missing out in, and what is the balance for the children themselves. So today it was just reported that now in the US, 500,000 children have been infected with COVID. So these are, although at a much lower rate overall, children still get infected. And I think you can look through all these different statistics and see what the overall case effect is as far as testing. Many children are testing. They're testing positive depending on what state and what area. Somewhere between 3 and 17%. Hospitalizations, although much lower obviously than adults, particularly older adults, are still occurring for children, less than 1% to about 9%. And mortality, in many states, the mortality for COVID in children is still 0, but not in all states. And there are some who have succumbed to the virus. Next slide. So when we look at it, there's a number of good studies that have been done now about what is the infection in children. So this is looking at a meta-analysis of 131 studies showing that they do get fever, they get cough, they have evidence of pneumonitis and pneumonia on x-ray. Again, a very, very low mortality rate. And then this very unique aspect to children of this multi-system inflammatory syndrome that occurs in a very small percent of children, but it seems to be quite significant. And then, of course, overall, their prognosis is quite excellent. So they're more asymptomatic, less morbidity, mortality, less low risk profile, less transmission. This is still being debated of how much transmission can children do and at what age does the transmission become equal to that of adults. And then although this multi-inflammatory syndrome exists, it's still a very low risk for most children. Next slide. So what are the stakeholders to do? So the stakeholders are the school and the administrators, the students themselves, and the students' parents and caregivers. And they are really essentially needing to follow, each one of them, a set of guidelines so that as much safety is as possible is going to be associated with getting our kids back into the physical environment of school. So what must be guaranteed is physical distancing measures. This involves the children themselves as well as the environment, shields in certain areas, and certainly in enclosed spaces, cleaning and disinfection, air circulation, testing and screening, face coverings and PPE, and then of course the unique aspect of what about children with disabilities, and included in this is diabetes. So the parents have to agree really to a number of safety measures for their children. The children have to follow them. And then of course the school, the onus is truly on the school itself to provide these physical attributes so that safety is at the maximum. Next slide. So what are the opinions that parents have about sending their children back to school? This was a cross-sectional study done, a survey done in the beginning of June. A number, about 700 parents involved across racial ethnic groups. 31% would probably or definitely keep their children home in the fall, but almost 50% were looking for ways to feel comfortable and safe in sending their children back to school in the fall. So across socioeconomic status, but the real issues are we have to address the concerns of the parents who must feel comfortable in sending their children back to the physical school environment. Next slide. And what about children with special needs? So children with diabetes are, again, not at greater risk for contracting COVID, as Bob just showed for the adult population, but they are at greater chance of metabolic derangement if infected, including at high risk for diabetic ketoacidosis. And this is actually seen in children or youth with type 2 diabetes as well, with the concept that perhaps the viral infection in some way is impairing insulin response or perhaps infecting the beta cell itself. Diabetic ketoacidosis can be life-threatening. And if we do send our kids back to school, who's going to help manage those who need that kind of help while they're in the school environment? And this must be done in compliance with the Americans with Disabilities Act, but can it actually be achieved now in what is a very, very altered environment when we do send our kids back? Next slide. So kind of in conclusion, there's no doubt that children need to be in the physical environment of school for a variety of things beyond learning. And that the schools have a tremendous onus to be able to supply that safe kind of environment where there's all kinds of added things now done to the classroom, including reducing class size. So a lot of increased costs associated with adhering to the public health guidance, and in the face of states with plummeting state and local tax revenues to really be able to finance this additional aspect of education. So it has to be a commitment really of all of us, that somehow we will work together to find the support needed to confront the COVID-19 infection in a safe, healthy, and thriving environment for our children and youth as we look to send them back to the physical environment of school. So thank you very much. I'm looking forward to answering some questions when there's time, and I'll send it back as well. Thank you.
Thank you so much, Dr. Kaufman. Next, we are happy to have Kelly Close, and Kelly will be sharing more about employer best practices and the potential for telehealth for diabetes patients. Kelly Close is an American writer, speaker, and advocate for people with diabetes. Kelly is the founder of Close Concerns and Diatribe, a nonprofit established in 2013 to improve the lives of people with diabetes and prediabetes and to advocate for action. Kelly is the author of over 35 peer-reviewed manuscripts and the author of an award-winning book published by the ADA in 2013. Kelly, thank you again so much for joining us. Over to you.
Oh, it's such a privilege to be here and on such an amazing panel. So thank you so much. We'll just go to the next slide while I just talk a little bit about what I want to share with you today. I've been asked to talk about employer best practices. I think because I'm a patient, I've had diabetes for almost 35 years. Thank you to Virta for giving patients voice in so many different ways. Before starting Close Concerns and diatribe.org, I was really lucky to work with several employers who had amazing health plans and really helped enable higher productivity and made me feel more successful as somebody with diabetes. And I've been thinking a lot about this in the time of COVID and about how we can all work toward being our best selves. And we can go to the next slide. Thank you. I just want to say, to start, what do people with diabetes want employers to know? And I would never try to speak for everybody with diabetes, but these are just some, thoughts. You can make a difference. You can help us feel seen. We're an investment for you, not a cost. If things work out the right way, especially all the ways that you can help us work toward, heart health, kidney health. We never have to have any of these problems if we start out and if you can help us be strong. I think COVID-19 can really be a catalyst for everybody to be as world-class as possible. And especially as I think about employers, telemedicine is something that Virta has been doing forever. It's beyond telemedicine with them. They've made virtual care world-class care. And that's an art, it's a science. These leaders are phenomenal, and it's amazing to be here with them. Dr. Kaufman has been a longtime advisor of Virta. She's magic. The same for Dr. Ratner, Dr. Hallberg, Dr. Harrison. They think about this in just very intentional ways. Diabetes isn't a character flaw. Working with us toward helping improve our physical health is huge. And as Dr. Kaufman spoke about so eloquently, that's physical well-being, that's also emotional well-being, mental well-being, and we know that this is important in the broader field as well. So we can go to the next slide. I'm gonna run through some of this really fast. I know you know all of this. We hear a lot about the big costs of diabetes. These costs only come every 5 years, so this is a little bit old data, but the cost of diagnosed diabetes being well over 300 billion. Often we hear, 90 billion is reduced productivity. But besides that, no, that's big. That's something that really gets overlooked that I'm really going to focus on today. The other 237 billion in direct costs, that's of course massive. We can do so much better on this downstream as an ecosystem as we kind of think upstream about what to do. And again, as employers, as health plans, you can make such a big difference here. So let that sink in now. $90 billion due to lost productivity. We as patients are also losing productivity that we don't need to lose. And I often think about this amazing social scientist at Stanford, BJ Fogg. He is really helped Diatribe think more about this. He's got kind of two big beliefs: help people do what they want to do and help people feel successful. help people feel successful. And employers, health plans, strategists, you have so much opportunity to do this. So many of you are doing it already. Thank you. Patients, each day that we don't have the chance for optimal care, we're losing productivity in the workday. Our employers are losing the chance to have success associated with our whole selves being there. We lose this in sick days. We lose this even at work sometimes when we're not on our game as we could be. And, we know this can be different. That isn't just about digging further into the ecosystem, into a hole of long-term medical costs. That is happening. That doesn't need to. And again, so many patients, so many people who are associated with Virta and the Virta Health Clinic, that is all about feeling successful. By the way, employers, people with diabetes we're losing productivity on the weekends and at nights if we're not able to do as well as we could do. You want us all to be our best selves in terms of physical well-being, emotional well-being. You can have this impact too with more deliberate action. So I'm going to go to the next slide. Just to level set us, and this is DQ&A is a social enterprise that's really committed to helping make life better for people with diabetes. I helped found the organization back in 2009. We help harness patient and healthcare provider voices to help answer some pretty key business questions that I'm going to chat about, develop better products, services, policies. This is all about improving health outcomes for people with diabetes. And I think we're really trusted by patients because of our independence and our commitment to diabetes. Patients, if you want to be part of this group, just write to info@d-qa.com. But just wanted to show you here, based on this survey of 5,000 people, people with diabetes are, of course, in the time of COVID, facing increased challenges. Some work that they did showed that that unemployment was actually 18% for people with diabetes compared to the national average of 12%. That was a few weeks back. We also saw that people with diabetes were rationing medicine, supplies. First of all, we would rather have patients just need less of that. But just to say, you might think that that's always about people who are unemployed. It's not. Sometimes it's largely people who are underinsured. And again, you can change that. I'm going to go to the next slide here and just to say one more thing about productivity, fewer sick days. You see some of that detail there, but happier employees. The field can be out there really investing in more robust health plans, and it's investing because of course there's an initial investment, but the payoff is incomparable. So there are a bunch of things that you can do there to make sure that we're working toward health, we're working toward prevention of all of that stuff that we don't even want patients to have to deal with at all. And it is possible today because of some real strides on the science side. And, again, this is the time to be thinking about prevention, about preparedness, and all of that. So many of those things, like get patients off sulfonylureas as an example. They don't need to be gaining weight. They don't need to be experiencing hypoglycemia. They don't need to be taking those at all. I'm going to move now into what have the attitudes of patients with diabetes been toward virtual care. And I'm going to speed through this. I think we go to the next slide here. As we all know, telehealth, and we'll just keep going to one more slide. As we all know, telehealth has expanded massively. It's increased from 0.17% of medical claims, that was in March, to 7.5%. As we go, that was even a few months ago, and it's even higher right now. In this DQ&A data, we can see more people are beginning to take up telemedicine. They like it. We can keep going here. And we know that telemedicine isn't perfect yet for every patient, but the DQ&A data from April shows like 84% of patients, even just at that point, were satisfied or super satisfied with their telehealth experience. Again, the Virta Health Clinic has been doing this for a while. I have really admired it long term. We have been watching this very closely. We know, again, it's not all one size fits all, but why not go with the leaders? We're going to keep going down and go through some of these slides quickly, but just to say, virtual visits, again, by those who really know it, really encourage the sharing of data with doctors. And there's something equalizing about seeing your doctor on the screen, moving to sharing data and using the data to work on our health. Diabetes is unique because it's really data sensitive. So changes in glucose, exercise, medication, if we need to take that can all be captured and quantified. So the telehealth visits are where data can be easily shared and then really used to inform interventions. We also know time and range is becoming a big part of diabetes, and it's much easier to share time and range. That's a new standard of care. Just measures how much of our day is spent there. How much of the time are we doing optimally? And that can be really helpful as well. We'll go down and just go through those slides quickly. Yeah, keep going. Keep going. Thank you. Yeah, and that one is big. Just to say, if you can just flip up to that for a second. Over telehealth, it's so much easier to show if we can even move from 20 to 25% time in range, 70% is where we want to get, then that's an hour a day more productivity. So thank you very much. We'll just flip through to the end of the slides. That's the end of my presentation. You can see my family and my team at Close Concerns and Diatribe. They do so much to help me be as successful as possible with diabetes. And now I'll hand it back. Thank you.
Thank you so much, Kelly. Next, we have Dr. David Harrison, who will share the latest updates on telemedicine laws in the U.S. Dr. Harrison is the Vice President of Clinical Care at Virta Health, where he leads the medical team and runs Virta's network of clinical quality initiatives. Dr. Harrison has worked in many different areas of virtual care and telemedicine for over 10 years, including medical director and vice president of clinical quality at Best Doctors, and later vice president of physician affairs at Teladoc. Thank you so much, Dr. Harrison, for joining us.
Great. Well, thank you, Sarah, for the introduction. And holy transforming telemedicine, Batman. These are remarkable times. And as we reopen America, we know that telemedicine is going to continue playing a significant role in the US healthcare system. Yet we find ourselves wondering where we'll be when the dust settles. So today, I'd like to talk about how this transformation occurred so darn quickly and chart both the dramatic rise and now some relative decline of telemedicine's prominence vis-a-vis office-based ambulatory care. And then, most importantly, I hope to excite you about the potential awesomeness of continuous remote care as a new paradigm for disease management. So how and why did this transformation occur so quickly? Well, when COVID hit, it was pretty clear that the US healthcare system was really up a creek without a paddle. Waiting rooms were seen as dangerous places to be, and many ambulatory offices shut their doors. And so telemedicine existed, of course, but there were so many restrictions and regulations that cumulatively resulted in a burdensome morass. And relatively anemic reimbursement was another headwind. So, as a country, what did we do? We unshackled telemedicine, at least temporarily, as emergency measures sprung up faster than you can say government bureaucracy. Many states implemented pathways for expedited temporary licensure, and other states were even more relaxed, granting full reciprocity to physicians with an active license in another state. These changes enabled tens of thousands of physicians practicing telemedicine to quickly increase their geographic reach. And then there was explosive action at the federal level. Over 30 emergency federal policy changes. HIPAA rules were relaxed to allow the practice of telemedicine on platforms such as FaceTime and Zoom. Medicare and Medicaid granted waivers to in-state practice requirements. And for those of you who are old enough like me to remember Jerry Maguire, one of the biggest factors, of course, was show me the money. Money was poured into telemedicine, initially providing $200 million in funding via the Coronavirus Aid, Relief, and Economic Security Act for health systems to implement telemedicine programs. And remarkably, really remarkably, CMS established parity of reimbursement for virtual visits, and many private insurers followed suit, often as a result of state telemedicine parity laws. In this completely changed environment, patient and physician adoption of telemedicine increased dramatically. Patients who never previously considered downloading a telemedicine app and doctors who insisted on the necessity of putting a stethoscope to the chest were now receiving and delivering care virtually. But now we're seeing something that may be a little surprising. Following an initial meteoric rise of telemedicine, when in-person care was all but inaccessible, we're now seeing a relative drop-off, even though we're still in the throes of the pandemic. This figure is from Epic, which is, as you all know, a massively distributed electronic health record. Telemedicine visits went from less than 1/100% of all ambulatory visits to 70% in only 1 month. Again, holy telemedicine transformation, Batman. It's also important to note that although this is likely representative of ambulatory practices nationwide, this data does not include totals from the national telemedicine companies such as Teladoc, MDLive, and Doctor on Demand. So let's also take a look at this in terms of volume. Total volume of ambulatory telehealth visits increased 300-fold in 1 month. Wow, peaking near 2 million per week in mid-April. But thereafter, despite an overall increase in total ambulatory visits, there's been a modest decline in telemedicine visits. So telemedicine definitely has a much larger presence in the US medical system, but it also doesn't seem to be replacing brick and mortar care to the extent that some of us, myself included, may have guessed a few months ago. So why not? Well, there probably are many reasons, and lots of folks are working hard to figure this out. First, there's patient preference. Although it may be surprising, given what a hassle it is to get to the doctor's office and wait in the waiting room, people really do like seeing their doctor. For doctors as well, and I include myself here, it's actually really nice and helpful to see my patients in the office and not have to wrestle with telemedicine technology, even if it does mean having to put on a nice pair of pants. I am wearing shorts right now, but that's beside the point. Obtaining labs at home is possible, but not yet commonplace, and the need for testing brings patients back to the office as well. So national telemedicine companies are very often working outside of a patient's primary electronic health record, and this fragmentation of information is another headwind slowing growth. Few practices have gone totally virtual, and thus the considerable overhead of maintaining a physical site remains. And then, in some ways, virtual care may still be at least a bit of a gamble because so many emergency reimbursement changes have yet to be made permanent. All of that said, the telemedicine is here to stay. As mentioned, patient adoption of telemedicine and physician comfort with this care modality are far greater now than in the pre-pandemic world. And although there are many question marks regarding reimbursement, it's pretty clear that there will continue to be a huge amount of healthcare spent in telemedicine, even if virtual does not become the new nationwide standard of care. And there also is a boatload of proposed legislation that could make many temporary changes permanent. And I've just listed some of them here. Professional societies, including the American Medical Association and the American College of Physicians, are lobbying in support of telemedicine as well. And thus, there is tremendous opportunity if we have the creativity and the courage to think outside the box, not just to recreate our standard episodic care model on virtual platforms, but to do something greater. And what is that? Well, I love being a primary care physician and working at Mass General, and I care deeply about my patients. However, rushing through a complex visit in 15 minutes, ordering some tests and tweaking medications, then sending the patient off to do the same for the next in line, sometimes leaves me feeling a bit like I'm a clerk at a ridiculously busy checkout counter. This is not always the most satisfying or effective model for care. How much better would it be to have a continuous remote care paradigm in which clinicians are manning metabolic mission control centers, virtually rounding on hundreds, even thousands of patients to deliver care proactively based on clinical need? And this, in essence, is what we're doing every day at Virta in treating diabetes, which is a chronic disease that is particularly well suited to a continuous remote care paradigm. Numerous patient biomarkers and clinically relevant symptoms are acquired via a user-friendly app. Then these data are integrated by an AI-enabled platform that brings to the fore those patients whose biomarkers demand it. Blood sugar too high or too low, blood pressure too labile, and all of this is modulated by the complexity and hypoglycemia risk of the patient's medication regimen. And here's a snapshot of what it looks like. Clinical data and trends over time can be reviewed at a glance. Both the patient's health coach and the clinician can chat with the patient, as you see on the right of the screen. And modifying the care plan is needed and providing ongoing behavioral support. This continuous remote care paradigm is a gratifying, and for me, I have to be honest, it's really fun way to practice medicine. And it enables us to attain therapeutic targets much more safely and more rapidly than with standard episodic care. So continuous remote care can do what is so hard to do in traditional ambulatory settings, to support transformational, sustained lifestyle changes and embed the medical oversight required to ensure that such changes are made safely and according to evidence-based protocols. And of course, I guess some would say I'm a little biased because I left the world of episodic telemedicine to join Virta, but I believe that almost every patient with type 2 diabetes in the world can benefit from this paradigm. The science is powerful in its simplicity. When people eat carbohydrates, their bodies need insulin. However, people living with diabetes can't produce enough and blood sugar increases. Dietary fat, however, requires zero insulin to metabolize. Thus, by replacing dietary carbohydrates with dietary fat, patients' insulin requirements are dialed down to a level where their bodies once again can compensate. Blood sugar goes down, the need for diabetes medications diminishes, and metabolic health dramatically improves. And the data speaks for itself. The top graph shows a sustained 2/3 reduction in the need for diabetes medications. In the bottom graph, Virta again delivers a sustained decrease in average blood sugar over the years, despite medication deprescription. And so although when I got my first prescription pad almost 20 years ago, I was so excited by the awesome privilege of prescribing medications for my patients, now with less hair, I am so much more excited about de-prescribing medications as my patients are empowered to make lasting improvements in their health. So, in conclusion, we have seen absolutely unbelievable growth in telemedicine as a result of COVID-19. But current trends suggest that telemedicine may still be far from eclipsing traditional office-based care. These are dynamic times, and it's difficult to know where the new equilibrium will be. That said, we are writing medical history as we speak, and during such a transformative period, we have the opportunity to embrace new, more effective, more empowering paradigms for patient care. And I wish it didn't take something as terrible and tragic as the COVID-19 pandemic to drive this kind of change. But now that it's here, we can work together to build a virtual healthcare system in ways that can transform patients' lives for the better. Thank you so much.
Thank you, Dr. Harrison. And we have time for some questions for our panel. So if everyone could come back and join us. Our first question that came in is actually a general question, so anyone can feel free to answer this, which is, how should diabetes patients, employers, and other stakeholders put their resources, and I presume that is manpower, that is financial, that is trying to manage chaos and time in general, to prepare for the impending flu season, which of course is going to coincide with this continuing pandemic. So what do you think? How is flu going to impact this, and how should we begin to prepare?
I'll take a first crack at this, Sarah. People with diabetes have been known for 100 years now to be at higher risk for getting infections. But the reality is that they're not at higher risk for getting them. They're simply at higher risk of having morbid courses. So the idea here is get a flu vaccine early. before the end of October. And for people at high risk, they should be getting it now before the end of September. Keep your glucose levels under control because, again, just like with COVID-19, it appears as though glycemic control plays a major role in the propensity to get sick once you get infected.
This is Fran. I would add certainly get the flu vaccine, and this should be imperative, particularly for children, as we hopefully do get them back into the physical school space. But I think testing also really needs to be, significantly changed, and we need to be able to do rapid testing, on-site testing, repeated testing, so that we can differentiate influenza from COVID.
Thank you.
Just to say quickly also, as patients or as workers, for everybody, it's so easy to put this off and just go do it.
Thank you. I think that's definitely wise words. Fran, this question comes from Charles, specifically for you. Realizing the value and importance of getting our children back to school, it appears that this message is not being communicated by the media to the general public or is being misrepresented. How can this be addressed? How can medical professionals and organizations do better at communicating this crucial message to the American public?
Well, I think it's a combination of perhaps for some areas, depending on the infective rates that are going, it may be a little early. I think there are a number of hits that the American Academy of Pediatrics actually took when they came out with it. It is an imperative to work to get our children back to the physical school space. Now, I want everybody to understand our kids are in school, right? They're on Zoom school, 50 million of them on Zoom school. My two little 5-year-old granddaughters are doing Zoom kindergarten. And in some ways there is some socialization, some learning, some benefit than no school at all. But we do need to get back to the physical space. But it has to be where there is that safety guaranteed inside the school. So more school expenditure. So maybe the best message is we need to support the schools with whatever revenues are available. And then obviously we need to push forth testing. Testing will be very important when we do this. But I think the data is clear that, and it's very well articulated in the piece from the American Academy of Pediatrics, of the overarching holistic benefits of school. And I think we should not take that from our site, from our lexicon, from our writings, and from our policy.
Thank you very much. Dr. Ratner, this question is for you. What are your thoughts on the COVID vaccine related to diabetes? Could it be just as effective for patients with diabetes?
So in general, vaccines are equally effective in people with diabetes. So whether it's the flu vaccine or it's the chickenpox and mumps vaccines, we recommend them in particular for people with diabetes. Clearly, there is very limited information right now on the presumptive COVID-19 vaccines. You may have seen that one of the companies has stopped their study for safety reasons, at least to explore one adverse event. So what we need to do is make sure that people with diabetes are part of the vaccine trials so that we know whether or not it works in people with diabetes. But once a safe vaccine becomes available, I would encourage everyone with diabetes to get it.
I think that's excellent advice. Kelly, this next question is for you. What advice can you offer for those with type 2 diabetes who have recently been unemployed? And although this particular person asked about type 2 diabetes, I think the same exact question would apply really to anyone with diabetes.
Yeah, I mean, thank you for the question. I feel for you, and there are so many of the people with diabetes who are experiencing more of this. One thing is that if you are on any medicine, the patient access programs from different companies actually are very good. All of them might not be as visible. So just as help with medicine, that's one thing. Please make sure if you're taking medicine to look at those. Diatribe.org/access has a lot of that information. I also know, from the perspective of food, from the perspective of well-being for your family, there are more resources available. I know that others on the panel also might have ideas on this, exactly what to look for. But we have a big story at Diatribe that just went out this morning about, checking to all of the things that we can do to help us be as healthy as possible. And I just say we all need to vote to make sure that the governments are creating social safety nets here like they are everywhere. I hope it's all right that I say that. Others on the panel might have some suggestions on this too, but my gosh, thank you. And I'm so sorry for everybody experiencing this.
Thank you, Kelly. And one more time, could you, for everyone who's listening, could you give that address again of where people can go to find out more information if they're struggling with paying for?
Absolutely. That's diatribe.org/access, and I will put that in chat as well. And thank you to all of the employers. Please go out of your way to do as well as you possibly can for all of the people.
Thank you. David, looks like this question is for you from a physician. From the point of view of a doctor, what were the biggest changes you experienced when you transitioned from episodic telemedicine model to a continuous remote care model?
Oh my gosh. I mean, I said it before, but fun is one of the parts of it. Whether I'm in person or virtual, I average, and I think a lot of primary care doctors do, seeing about 2.5 patients per hour. If I'm super busy and it's urgent care, maybe up to 4. But doing continuous remote care, I can virtually round on and briefly communicate via chat with 15 patients or more in an hour. So just the number of patients for whom I can provide care goes up tremendously. And then when one combines it with the ability to see biomarkers and relevant data, having a platform that brings the relevant data right in front of me so that I can, it almost brings back memories. It's not quite like being in the intensive care unit, but just of having this, being able to watch improvements and trends and be able to respond in real time instead of doing something and then waiting 2, 3, 4 months to see what the impact of that is. It really is transformational. So kind of the satisfaction of a shorter time horizon and seeing the impact of what I'm doing with my patients and the fun of being able to touch so many more patients on a regular basis are both very positive aspects of continuous remote care. Not that I'm leaving episodic care. I'm still there, still doing my job, still love my patients, but continuous remote care really is a breath of fresh air.
And I will say, as a physician who long practiced episodic care and has practiced continuous remote care now for a number of years, I concur. It is definitely an exciting and fun way to practice medicine. We are about out of time. I'm going to attempt to sneak in one more question that came to Dr. Ratner. What are our blind spots in what we don't know about COVID and diabetes?
Lots. We still don't know why some people are more prone to get sick and others are asymptomatic. We still don't know whether or not there's any genetic predisposition to COVID severity. We still don't know why some people have classic symptoms and others have very atypical symptoms. The cardiomyopathy, for example, seems to be a very unusual sign of COVID-19. Keep in mind that 10 months ago, nobody knew anything about this virus. That's how quickly everything has been moving. We've got the genetic code for it within 3 months of its being identified. We had antibodies generated against it for diagnosis within 5 months of it being identified. So we've made incredible leaps. But for everything we learn, there are 10 more questions that we have to ask.
Absolutely. Well, once again, I want to thank so very much our esteemed panel. Thank you everyone for joining us. If we did not get to your questions here today, please feel free to email us at partner@virtahealth.com, and we will get back with you with an answer. So again, I want to thank everyone once again for joining us. What a wonderful privilege it's been to be here with all of our panelists. And everyone, have a wonderful week and be safe.
And thank you, Dr. Hallberg, for great performance in getting us all on time as much as possible.
Well, thank you all very much. You were all wonderful with that as well.